Hello again. Just to remind you, I'm Dr. Simon Petrides, musculoskeletal and sports physician at the Blackberry Clinic and medical director of the Blackberry Clinic Group. And this is the second part of the lecture on prolotherapy, which was given on behalf of Queen Mary's University London and for podiatrists, physiotherapists, sport and exercise medicine physicians, and musculoskeletal physicians. Just as a matter of interest, on the first slide, you'll see a demonstration of the anterior draw test used for assessing ankle instability, particularly in patients with deficiency of the anterior talofibular ligament. If you look at the X-ray on the left side, talus is sitting nicely under the tibia, and when the draw is applied, a posterior force is applied to the tibia, an anterior force applied to the foot and the talus, then the talus is now sitting anterior of the fibula. That is a positive test and is likely to indicate anterior talofibular ligament disruption, tear or partial tear. And the other image showing some of the ecchymosis and bruising that might happen as a result of that type of injury. So before the break, I gave you a case study, a 45-year-old lady with a previous history of inversion ankle injury and a deficient ATFL, but no other significant injury. So hopefully you've come up with some diagnoses, and obviously the anterior talofibular ligament partial tear is the main diagnosis there, the resulting instability. But this patient also has some anterolateral or fibular impingement, which is often a result of the anterior talofibular ligament injury, where the fibula impinges on the talus in passive dorsiflexion. This may also be an indication of sinus tarsi syndrome, which is some disruption of the ligaments within the sinus tarsi that you can see here, and is often differentially diagnosed based on the site of tenderness, whether it's over the sinus tarsi or actually up against the border of the fibula. Now, you've excluded other causes, but you haven't yet had an MRI scan, because I don't believe the MRI scan is needed to start treatment in this case. There's the added expense, plus there is no other indication on this patient's history that any other injury has taken place. So one way of preventing the impingement is to correct the subtalar overpronation with orthotics, which will also be helped by giving the patient stabilizing exercises, proprioceptive stabilizing exercises, and low dye taping. So in this case, the patient's pain has improved, but it still persists, and she's come back to you saying it's still hurting. This is when you would consider ultrasound guided or blind, anatomically guided prolotherapy, dextrose prolotherapy injections using 15% dextrose into the area of the ATFL injury and into the sinus tarsi if necessary, and the pain usually will improve. Now, you could make an argument for steroid injections to reduce the inflammation, and they can also work, but it can be temporary. Does it make as much sense as strengthening and toughening the connective tissue of the ATFL? I don't think so. And therefore, you can choose steroid or prolotherapy injections, And if there's no help with that, then the MRI scan may be considered to exclude other pathologies such as osteochondral defects in the ankle joint. So there are many other sites that you can use prolotherapy, particularly the MCL, ATFL we've talked about, the calcaneofibular ligament and the high ankle sprain, the anterior inferior tibiofibular ligament, can also be treated with prolotherapy, particularly if they have grade 1 or 2 tears. And there's the intertarsal ligaments of the foot. There is varying success with these in treating these ligaments, and some are backed up by studies and some are backed up just by anecdotal experience. The intervertebral ligaments are often treated, and certainly at the Blackberry Clinic we're doing a lot of prolotherapy in the lumbar spine and sacroiliac joints, the facet joint capsules, the iliolumbar ligaments, and supraspinous, interspinous ligaments. This can be extremely successful, particularly if the diagnosis is made correctly of a lumbar instability or a sacroiliac joint or pelvic girdle instability. You can also use prolotherapy at the tibialis anterior insertion in the navicular, peroneus brevis, in the Achilles, and tib post at the insertions, particularly if you don't want to use steroid. Some people don't. There's been some work on intratendinous dextrose injections in prolotherapy, in Achilles tendinopathy, and particularly some evidence on plantar fasciitis that it's helpful. There's a lot of work being done that's come out of Wisconsin, University of Wisconsin, by David Rubego on intra-articular and extra-articular prolotherapy in treatment of knee OA, with significant improvement compared to saline or normal therapy. It can be also used to treat the first MTP joint strain or pain, hallux valgus, bunions, and first CMC joint on the base of the thumb. More recently, there's been some research on perineural injections. Dr. John Liftoft from New Zealand has done some research and teaches on this subject using 5% dextrose solutions around nerve pathways for treatment of neuropathic pain. It has a particular effect on modulating the sensory A delta and C fibers and their ion channels, as I discussed earlier. More recently, again, there's been some work on perineural hydrodissection, particularly in carpal tunnel syndrome, by David Rubego and Dean Reeves. Now, here's some more specific examples of treating lateral ankle ligaments with prolotherapy. Here's on the top left, a normal anterior talofibular ligament, showing there's the talus, there's a fibula, and normal fibrillar pattern of the ligament structure. Then with a chronic ATFL injury, you've got some neovascularization, you've got disruption and heterogeneous appearance and reflectivity of the area with some effusion just deep to the ligament. Now on this slide, you'll see some of the needle pathways where you can inject either end of the ATFL. And this ultrasound image shows some of the needle pathways to inject either end of the calcaneofibular ligament running under the peroneal tendons from fibula to calcaneus. In what is called comprehensive prolotherapy, where several sites are injected. These are some of the other sites, like the bifurcate ligament, peroneus brevis insertion, intra-articular injection, the CFL, ATFL, AITFL, and the interosseous membrane can all be injected to stabilize the lateral ankle and prevent recurrent inversion injuries. Now, there's a lot of work being done in the past on lumbar instability, and here's a figurative diagram of some of the injection sites in the intervertebral ligaments, the interspinous, supraspinous ligaments, the facet joint capsule, the iliolumbar ligaments either end, the posterior sacroiliac ligaments, and interosseous ligaments. These can be done in a 3-minute injection under image intensifier. And strengthening those intervertebral ligaments will assist the muscle stabilizers, the tonic and the phasic stabilizers, by the injection into the intervertebral ligaments, and the two structures together can have a significant effect on stabilizing lumbar spine, and several studies have shown a significant reduction in pain, often with associated physiotherapy-based lumbar stability exercises. In OA knee, but also other ligament injuries of the knee and other conditions, this is some of the teaching that is used by the Hackett, Hemwall and Patterson Foundation and the Pain School International in Budapest. You'll see some of the colored circles and arrows where the coronary ligaments can be injected, access to the intra-articular space, then the retinaculum, quadriceps tendon, and patella tendon. Then we've got the lateral side of the knee where the injection can be made along the lateral collateral ligament from origin to insertion, the anterior, the proximal tib fib joint, and then the coronary ligaments, along with Gerdy's tubercle at the insertion of the iliotibial band. On the medial side of the knee, you've got several sites of injection around the pes anserinus and bursal area, with the medial collateral ligament, origin and insertion, and the medial coronaries with the adductor tubercle. Popliteus insertion is often injected on the medial border, posterior border of the tibia also. There are some other ultrasound images showing the medial collateral ligament being injected, medial patellofemoral ligament being injected at the patella, the origin in the patella. Then you've got the medial collateral ligament being injected. And these are the other trajectories of the needle to inject several different structures under ultrasound on the medial side of the knee. Again, more diagrams on this slide showing injection points. And with such a complex arrangement of ligaments, you can see how you may be able to achieve better stabilization of the knee by thickening and strengthening these collagen fibers and ligament insertions. Here are some more drawings from the Hackett, Hemwall, Patterson Foundation and Pain School International in Budapest over the lateral ankle ligaments, ATFL and AITFL, all of the ligaments responsible for stability of the lateral side of the ankle. Then the medial side, where overpronation can strain spring ligament, a short plantar ligament, along with the deltoid ligaments, which are often involved in external rotation ankle sprains. Again, there's the first MTP joint and the capsular ligaments that can be injected with dextrose, plantar fasciitis, and then evidence of other areas that can be injected, the medial plantar arch and the Achilles insertion. So why would you particularly want to use prolotherapy? Now, these are extremely strong reasons to use a particular technique, particularly if altogether they apply to one type of treatment. So first of all, prolotherapy has been shown by several systematic reviews to be an effective treatment. In knee OA, in low back pain, in plantar fasciitis, and Achilles tendinopathy, all the reviews suggest that it is an effective treatment. It is also safe. There are some concerns about steroid injections, particularly if they're repeated, but there is no concern on repeated injection of dextrose. Several meta-analyses, in fact all of them, have shown it is a safe type of treatment to do. It is particularly inexpensive. A vial of 50% dextrose only costs a few pounds, and some lidocaine and saline is equally inexpensive. So those three are particularly good reasons to use one type of treatment. It is fairly easy, but you do have to have training. It is worth going to some of the training programs around the world and watching this type of treatment in action. It is also a useful adjunct to rehab. Muscles and ligaments stabilize joints. The physical therapies are extremely good at rehabbing muscles, but patients are not able to rehab their ligaments themselves. Orthotic inserts in shoes can definitely help to support the subtalar joints and control the joint. Taping can assist in the same way as can manual therapy. They can all be useful and should all be used as appropriate at the same time as doing prolotherapy. It's a good option if you found steroid has not helped. You may have used hyaluronic acid or autologous blood or PRP, and if there's been no result, steroid is there as a backup option as the patient sits in front of you and says, now what? What shall I do, doctor? What's next? I believe it's the first option of treatment in certain conditions such as lumbar instability or sacroiliac joint instability, which have not responded to physical therapies. There is some anecdotal interest from football physiotherapists who believe that in acute ankle sprain, then dextrose prolotherapy can significantly shorten the time to return to play. And also, if I said that you had, I said earlier, some people have a concern over using steroid injections, particularly in the recent coronavirus crisis, or repeated use of steroid injections, which may have a detrimental effect to connective tissue. Dextrose prolotherapy has a positive effect on connective tissue and pain. Patients who have multiple pain sites, such as those with Ehlers-Danlos syndrome, and people with multiple trigger points, they might have fibromyalgia. It can also be a very successful form of treatment. So why would you not want to use prolotherapy? Maybe in an acute pain or injury, apart from ankle sprain, as I mentioned earlier. Some insurance companies, particularly Bupa, don't cover prolotherapy. It does need 3 to 6 treatments, 1 to 4 weeks apart. I tend to use 3 treatments, and if the condition is significantly improving, we can do more. It's used by family practitioners, GPs in the USA, and so maybe they have better availability of recurrent consultations, but it's certainly very popular in America and increasingly so in Australia and New Zealand. In some sites there is limited evidence of its effectiveness, but anecdotally it can be very useful. And as usual, more trials are needed. The trouble is dextrose prolotherapy has no patent. You can't get a patent on sugar, so there is no pharmaceutical company willing to spend money on large clinical trials and meta-analyses. So there is no particular other reason not to use prolotherapy. One of my colleagues said it is sports medicine's best kept secret, and I said, why is that? And he said, because it works, doesn't it? So where can you learn to do it? Well, the Hackett-Hemwall-Patterson Foundation in the US, American Association of Orthopedic Medicine in the US, Pain School International in Budapest, and the Blackberry Clinic Group, Blackberry Education, have held courses in the past and are due to hold courses in the future, so do email me on that address if you're interested. So many thanks for listening, and for the benefit of the podiatrists amongst you, time wounds all heals, as we know. And at the end of this presentation, there are several slides of all of the evidence in vitro on the Achilles, systematic reviews and studies, systematic reviews in MSK pain, plantar fasciitis, and other references for you to peruse. Thank you very much for listening. It's been a pleasure sharing this with you, and by all means email me with any questions. Thank you.